Assalamu alaikum. Starting with the clinical case, we have Mr. Fields, 36 years, with complaint of difficulty of walking and painful knee swelling. We're starting in seconds. Okay, ready, Dr. Abdul Manan, Dr. Sarah?
Yes.
Yeah, here you go.
Hello, my name is Dr. Ahmed, one of treating doctor in clinic today. May I confirm that you are Mr. Field, 35 years old?
Yes, doctor.
Mr. Field, we are here today to discuss some issues related to your health and examine you. Is it okay with you?
Yes.
Can you please, in your own words, tell me what brought you to the hospital today?
Yes, doctor, I came today because I'm not feeling well. I'm having severe pain in my knee, in my right knee, which is for 2 days ago. And this caused me severe pain and discomfort. So I couldn't walk even.
I'm sorry about what you have been through, Mr. Field. I will help you as much as I can.
Okay.
Okay, Mr. Field, is it start sudden or gradually?
It started yesterday, all of a sudden. I have this swelling and pain in my knee.
Is it the first time or you have previous attack?
No, this is the first time.
Have you noticed anything increase this pain?
It's increasing and I couldn't move it. Any movement will increase it. And even I couldn't bend my leg.
Okay. Mr. Field, have you noticed anything make it better?
No, I'm trying to make elevation, do some rest to my leg, and also I'm putting ice packs, but nothing work.
Okay, I'm sorry about that. How much you grade this pain from 0 to 10?
7.
7. Okay, for now, I will give you, let me assess you, and then I will help you as much as I can.
Okay.
Mr. Field, do you have any past medical illness I should be aware of?
No, I don't have any past medical illness.
Okay. Is there any other any joint pain?
No, this is only the joint that I'm having pain in it.
Any joint stiffness?
No.
Any skin rash?
No skin rash.
Do you have any do you have any recent illness? I mean, pain during your water work?
No, I was having, I think 1 week ago, I was having some flu symptoms. I took some Redimi, but I'm still having this sweating and fever, which mainly at night.
Okay, okay. Well, do you have any frothy urine?
No.
Okay. Any change in your color of your water work?
No.
Okay. Any pain, any parts other than this joint pain?
Any what? Sorry.
Any pain? Do you have any pain? Any part other than this joint pain in your body?
No.
Okay. It came to my knowledge also that you have difficulty of walking. Is this difficulty of walking because of weakness or this because of pain?
No, because of pain, doctor. If you see my knee, you find it swollen.
Okay, okay. Do you have any feeling, any tiredness?
Yes, I'm feeling this week. I'm not feeling myself this week.
Well, do you have any feeling sick?
I'm feeling sick, yes.
And throwing up?
No, I'm not throwing up.
Any weight changes?
No, it changes, but I'm not eating this week because of this nausea.
Sorry?
I'm not eating well this week because the nausea that I'm having.
Okay. Any lumps or bumps, any parts in your body?
No.
Okay. Any eye pain?
Eye pain? No, I don't have any eye pain.
Any eye redness?
No.
Sorry?
No.
Okay. Any change in any vision problem at all?
No.
Okay. Any weak? Okay. Do you have any headache?
No headache. I'm having some headache with the fever, yes.
With this fever? Any back pain?
No back pain.
Any okay, any change, any since loss in sensation?
No loss of sensation.
Okay. Any change in your bowel habit?
No.
Any change in the color of your eyes?
No.
Okay. Have anyone noted that you have become paler than before?
No, doctor.
Any chest pain?
No, I don't have any chest pain.
Any shortness of breath?
No.
Any cough?
No, I don't have cough.
Any coughing of blood?
No, I just having only some flu symptoms, which is sore throat. Sore throat subsided, but I'm still having this fever.
Okay. Well, do you have okay. Do you have any history of admission before or surgical operation?
No.
Any family history of similar condition?
No.
Okay. Well, you don't have any past medical illness. Past medical illness should be aware of.
No, I don't have any past medical illness.
Okay. Well, do you have? Okay. Give me your medication list.
I don't have any. I'm not taking any medications.
Okay. Do you drink alcohol?
I'm drinking alcohol socially.
Sorry.
Socially.
So do you smoke?
I'm smoking 10 cigarettes per day for the last 10 years.
Sorry.
I'm smoking 10 cigarettes per day for the last 10 years.
Okay, Mr. Field, I advise you to stop smoking because the smoking generally affects your health. And if you would like, I will refer you to smoking cessation clinic.
Okay.
Do you drive?
Yes, I'm driving.
Is this joint pain affect your driving by any way?
I didn't try because I'm not able to walk now, so how I will drive?
Okay, okay. Okay, what's your job?
I'm working as the insurance broker.
Insurance what? Insurance what?
Broker.
Okay, and how did it affect your job and daily activity?
I didn't want to work till since I'm having this joint pain.
Okay, well, Mr. Field, I will give you sick leave for now, and then we will involve social worker to see how we will help us in this regard. Is it okay with you?
Okay.
Can I examine you?
Yes, please.
Okay, what about vital?
Temperature as seen, 38.1.
And temperature chart? Any temperature chart?
No, the fever is 38.1. Blood pressure over 60, otherwise normal.
Okay. Well, blood pressure and pulse rate?
Normal.
Okay, I would like to examine the knee joint.
Yes, you will find redness.
General look.
It looks swollen.
Mm-hmm.
If you palpate, there is crepitus and redness.
Okay.
And hotness.
And hotness. Okay. Well, Mr. Field, just I want to ask you if any history of trauma.
No trauma, no doctor.
Sorry?
No.
Any history of recent traveling?
No recent travel.
Okay. Or did you make any hiking recently?
No hiking, no.
Okay, Mr. Field. Okay, regarding the examination, what about movement? Restricted for all sides?
Restricted movement of the right knee.
Restricted movement. Okay. Any features of polycythemia? Any redness in the bone?
No.
Okay. Eye examination?
Normal.
Okay. Regarding this joint pain, the left one is normal, only unilateral.
Yes.
Okay. Abdominal examination?
Normal.
Any mouth ulcer?
No.
No blur at all.
Yes.
Cardiovascular examination.
Normal.
Okay. Regarding the soul of the food, is there any skin changes or
No, nothing.
at the bottom of food, both food?
The soul of the food, nothing. No.
Sorry?
Nothing.
Okay. Chest examination?
Chest?
Yes, I mean air entry, if there is any abnormality in air entry or deformity at all.
No.
Okay. Regarding the general look, any abnormal features?
No, the patient looks well on the
Normal.
unwell.
Okay. Height and weight.
Normal.
Okay. So back examination, if there is any deformity,
No.
I would like to just for general look, any kind of skin changes, skin rash or anything.
No.
Okay. Just I would like to do by torch if there is any eye redness.
No, nothing.
Okay. Well, I would like to back to the knee joint. You
Yes.
just there is the redness, hotness, and reduce in function, and there is crepitus.
Yes.
Okay. So I would like to ask you more question, Mr. Field.
Yes, please. No problem.
Just actually, I'm sorry about to ask you this private question. Do you
Mm.
have are you taking any recreational drugs?
Yes, doctor. I'm sometimes injecting heroin.
Heroin?
Yes.
Okay. For how long?
For 4 years now, but now I'm starting to decrease it because my wife is. I promise her that I will try to decrease my heroin intake. So I have it last week.
Let me appraise you because you decide this is the right decision. And if you would like, I will help you in this regard and refer you to the center that specialize in this matter.
Okay.
And share needle sharing.
Before I was sharing needle, but now I'm not sharing needle. Maybe for 1 year now, and that needle from the needle exchange program. They are giving me free needles, so it's good. I know that the needle can give me some infection, so that's why I'm not using needle now.
Okay. Well, any tattooing or piercing?
No.
Okay, Mr. Field. Sorry for this question. Any extramarital relationships?
No, I love my wife. We are married for years.
Let me appraise you for this, and I will help you as much as I can regarding this pain. Okay.
Okay.
Okay, Mr. Phil, what is your concern?
2 minutes left.
I'm concerned about this joint. Why I'm having this pain? I'm having this. I will have disability. I won't be able to walk, or what, doctor?
I highly appreciate your concern, Mr. Field. From what you said to me, and after I examine you, you most probably have a condition called septic arthritis. It is a medical term for medical condition in which there is introduced or this joint pain caused by bug, and this bug mainly due to this needle sharing or that because of unsterilized needles. So these bugs sometimes spread in your bloodstream and cause soreness in your joint, explains the symptoms that you have. What we need to do now is to do regarding your second concern, Mr. Field. I'm sorry to tell you that, but if this condition is not treated properly, I'm sorry to tell you that might cause joint destruction and cause disability.
But doctor, I was sharing this needle 1 year ago. So why I'm having why it is the cause now?
I highly appreciate your concern, Mr. Phil. Sometimes because this of recreational drugs may cause low immunity, and if I mean by that, it reduces the defense system. So that even that may relate it to the illness that you have before weeks or days ago. And in normal, your defense system may overcome of this infection. But in your case, because of this low defense system, may cause this spread of infection. Am I clear so far?
Okay, so you mean that I'm weak, that's why I'm having this infection, right?
Your defense system, yes.
Okay. Okay.
Okay. What we need to do now is to do some blood tests and imaging, and might need to withdraw just withdraw fluid from your joint, knee joint, and examine it under microscope to know what is the exact cause. Then we will sit together and to discuss proper plan of management, which involve joint doctor, blood doctor, and specialized nurse and occupational health doctor, and if you need any walking aid.
Okay, time is up. Let's go to the examiner question.
So what
Okay.
is your diagnosis? And
Sorry?
what is your diagnosis and your differential?
My diagnosis, I have differential diagnosis. My first differential diagnosis, septic arthritis, because of this fever and signs of inflammation. My second differential, it is goiter arthritis, but again is that this patient no any risk factor or triggering factor. The third differential diagnosis could be hemoarthrosis, but again that patient don't have any history of hemophilia or any past medical illness. My third differential diagnosis could be pseudo gout, but I didn't find any other. I didn't find any other evidence, I guess, confirm this is a pseudo arthritis, pseudo gout.
And what is the other symptoms that confirm pseudo gout?
Usually there is a history of, for example, a causes, underlying cause, like hemochromatosis.
Okay. Okay. And what is investigation you will do for this patient?
I would like general investigation, complete blood count, renal function test, liver function test, electrolytes, and inflammatory markers to know for diagnosis and to monitor the disease. Also, I would like to do joint scan, X-ray, and I would like to do needle joint aspiration to know is it septic arthritis or bloody for hemoarthrosis. Also, I would like to do looking for complication on background of shared needles. I would like to do echo to exclude any features of endocarditis because of this. He has fever already. This is regarding investigation.
Okay. And what's the treatment for this patient?
Treatment, general treatment, education, counseling, and counsel of the patient about his disease and the importance of to stop heroin and refer him to rehabilitation center for heroin stop program. Then this will do depends on the result of aspiration. If septic arthritis, we give him after culture, we give him suitable antibiotic. And also this will be multidisciplinary team involving orthopedic doctor and orthopedic surgeon, hematologist, and specialized nurse and specialized nurse.
Why hematologist?
Hematologist, if there is any if he has risk of septicemia, so we need to follow it by hematologist.
Okay. Okay. And what is and how this if this patient has septic arthritis, how is the cause of spread?
Sorry?
What is the commonest cause of spread of septic arthritis?
Sorry, again, the question. causes of spread?
Yes. What is the common cause of spread septic arthritis?
I don't know.
Okay. Okay. And what is the common if this patient? What is the common pathology for organism for septic arthritis?
Staph aureus.
Staph aureus. Okay. Okay. I finished my question.
Okay, thank you.
Yes, still 1 minute, Dr. Sarah. I can ask him this 1 minute.
Okay.
Okay. What other differential diagnosis, Dr. Abdelmenaim, you think about?
Apart from septic arthritis, gouty arthritis, hemoarthrosis, and osteoarthritis.
Osteoarthritis.
But again, is that osteoarthritis is not commonly caused? This is swelling and redness.
So you suspect infection. What other source of infection in this patient? You said blood, right? What other system can be affected and infected?
Reactive arthritis.
Yes.
Yes.
So which system?
For this patient, actually, he denied any symptoms of urinary symptoms.
In general, yes. So in general, urinary system, yes.
Yes.
What else?
Upper respiratory tract infection. And also already he has flu symptoms.
Yeah. So you have to rule out any other cause of infection, right?
Yes.
Okay, I'm done with the question now. I just filled the 5 minutes. You can now go to the comment.
I can
Dr.
ask
Sarah.
one question quickly. As you said, reactive arthritis. What is the common pathogens in reactive arthritis? Hello?
I forget actually.
Okay.
Lie?
We'll see it in the discussion. You did well. You did very well. You at the beginning, you forgot to ask about the clue, which is intravenous drug user, but you got it at the end. Okay. You ask about the sexual history, so that's good. These two things were the key for this patient, but you did لحقت نفسك at the end يعني. Okay. So yes, this patient he's presented his IV drug user. So and he was having flu symptoms. He's not sharing needle now, but that's why you need in the investigation to do full sexual health screen. Bloodborne, you need to check for hepatitis B, hepatitis C, and HIV. Okay, because this patient was sharing bleeding before. But I think the cause now of septic arthritis is not sharing the needle because he stopped sharing the needle for 1 year. So this is acute thing. It might be because he's injecting himself, sometimes not cleaning the area well. So he might have staphylococcus. Its most common cause is staphylococcal infection. You did well by excluded. So the differential will be gout, as you said. You did a good differential, and gout and pseudo gout. It could be Whipple disease. You ask about water work. You ask about history of travel. You need to exclude also history of travel, or even sometimes brucellosis can cause septic arthritis or osteomyelitis. Okay, one TB and brucellosis. You need also you excluded also you need psoriasis by asking about the rash, and also inflammatory bowel disease. Okay, and reactive arthritis, which can be the most common if this patient has erratic sexual history. So it could be reactive arthritis also, and the most common cause, as I asked you about the reactive arthritis, it's called Reiter syndrome. The most common sexual transmitted infection is chlamydia. Okay, and then Neisseria. Okay, and it could be reactive arthritis can be due to sexual transmitted infection, and the other cause it can be due to post dysenteric syndrome. Patient might have gastroenteritis. So the organism will be Salmonella, Shigella, Campylobacter, and Yersinia. Okay. This patient, you need to be aware he's intravenous drug user, so you need to check for the stigma of infective endocarditis, do an echo also for him, and stigma of infective endocarditis, pulmonary erythema, splinter hemorrhage. Okay, And the treatment that you said, you will give him antibiotic according to the intravenous, admit and give intravenous antibiotic according to hospital protocol. The investigation, you did it well, but the only thing I told you regarding the investigation, you can add the sexual health screen, okay, and the bloodborne infection, okay. This is my comment about the case. They can ask you in the exam the question about reactive arthritis, and that's good yet to ask about the rash in the palm of the sole of the leg, which is lenorrhea hemorrhagica, I think, for reactive arthritis. They might have keratinized brownish lesion in the sole of the leg if it's reactive arthritis. They might ask you in the exam what is the Duke criteria, so you need to be aware about the Duke criteria for diagnosis of bacterial endocarditis. So you know the Duke criteria, Dr. Abdullah?
Yes,
You know it, right?
for reactive arthritis.
No, the Duke criteria for diagnosis of infective endocarditis.
Yeah, major criteria, minor criteria for it.
Yes.
Yes.
Yeah, minor criteria. Okay, they might ask you this question, but you did it well. But the only issue, if you for the history, you need to put the sexual history and the drug use in your at the beginning, because you might know the diagnosis from the beginning. This is my comments.
Thank you so much.
Yeah, thank you, Dr. Sarah, for the case. Nice presentation, a nice case. Please, before starting comment, Dr. Abdul Manan, can you write the scenario for Dr. Sarah?
Yes, already in the
Yeah.
chat box.
Okay, so starting the comment, I will start from the late management. You mentioned the multidisciplinary team, and you mentioned one team is not necessary
Yes,
at all. Yeah, hematology. It's very,
yes.
very important to take care what you are inviting to your case. It might.
One of my differential is hemoarthritis, so I need to accept.
Okay.
Yes.
But also, it's not hemoarthrosis, so you haven't to recall them or to call them. It's not. I mean, it's not target differential in this case. I guess because no hematological condition, no trauma. It's clear like septic arthritis or reactive arthritis. Anyway, if you want to invite team here, you can invite the infectious disease team. This is the most important, yeah, for choosing the antibiotics and following the culture result, blood culture and septic aspiration from the joint, and for also upgrading.
Actually, I involved hematologists for two reasons, because for both the differential, that hemoarthrosis and pseudogout. So to exclude hemochromatosis, at the same time to exclude this hemophilia. I know that it's far away because no family history, the first time, everything, but I don't know.
Yeah.
So it's better to involve. Yes, but I agree. It's better to involve.
Yeah, make your differential try to make the differential make sense for you and for the examiner, and the team you also inviting also should make sense. Once you try to explain also, I want for to roll out hemoarthrosis and or hemochromatosis, he will tell you, did you have any signs of hemochromatosis, to call the hematologist to take over the case or to investigate the case. You don't have, so don't try to convince something which is not related. You already asked the whole question for your differential, and you got the diagnosis. Your diagnosis is correct. So don't go away from the case if you have clear diagnosis. Septic arthritis related to the drug abuse and injection, sharing the needles. No need to think about something is not related to the case. You got my point? Okay, yes. Let's go to the comments. Yeah, so you have to ask earlier about the movement and the pain. Is it related to the movement or the rest? So you will show the examiner that this pain is mechanical pain, right? And the mechanical pain will guide you to certain diagnosis, and the inflammatory will guide you to other causes. In this patient, clear, it's like mechanical pain worsening with the movement. I didn't hear you ask about relation to the movement, right? So you have to ask this question. to rule out the inflammatory cause of arthritis. Yes, the signs and constitutional symptoms here is very important to show and to magnify on, because it's systemic disease or systemic infection. Might be also bacteremia. The rash is very important to ask about. The redness and the eye affection you asked already, but these are the signs of reactive arthritis. You have to ask them in package. Cannot see, cannot be, cannot climb the tree. You know the triad of reactive arthritis. So try to ask this question together to conclude or to rule out reactive arthritis. Clear? Then the source of or any history or any previous infection is very important also. It can guide you to the case. Good thing here also you ask about back pain for discitis or any joint pain for spreading to infection to the other joint. Apart from this, you cover all the case well. When you are lost, try to ask for risky habit. As you did, you find some time to ask. But if you didn't, you'll be in trouble. You will not reach to diagnosis. Or you will reach to the diagnosis without knowing what are the underlying cause. In this patient, you have to ask about sharing needles or any tattooing or any casual relationships, unprotected sex. All these questions are risky habits. You have to ask it earlier if you suspect septic arthritis or reactive arthritis. Yes, you ask for the urinary tract infection, and she was denying that, but you have to catch the cause of the infection. Where is the source? And by the way, you have to send septic screening for all the system, including urinary, blood, and the aspirate from the joint. Okay. Apart from this, Dr. Sarah already mentioned how to start the antibiotics, the management, the investigation. The antibiotics try to be diplomatic and not pointing to one antibiotic or single antibiotic, unless the examiner asked you. But in this patient or any patient with infection, you can say, we will start antibiotics according to the guidelines or the hospital policy. If he asks you what the possible organism, for example, in this patient, Staphylococcus aureus. So what's the target antibiotics? So it's clear, vancomycin. Okay, this is the comment from me, and Dr. Sarah already mentioned the topic well. Let's read the comment before starting. Anyone has question? Yes.
Sure. I have a comment. Thank you very much for the case and nice presentation, actually. Again, like he mentioned already that the cause of the diagnosis septic arthritis is most likely due to the recreational drug use. So one important question we should ask, especially if we think that this is the cause. Like the same patient is presented with acute pancreatitis, we will ask when was the last time you drink, for example, if the cause is alcohol. So we will ask specifically when was the last time you injected heroin.
Yes, I told him.
Last time is 1 year ago or 1 week ago?
1 week ago. But he was using, he's not shaving needles. 1 year ago, he was shaving needles.
Okay.
Okay, you remind me, doctor, about also lymph node examination. It's very important here to check for lymphadenopathy. Anywhere, inguinal, offer for inguinal, of course, and do the cervical and virchow and axillary. But for inguinal, sometimes it's little embarrassing for the patient, so you can ask permission for examiner, but you should offer it. Any infection in any system, in any scenario, you have to do lymphadenopathy examination or lymph node examination. They are focusing and stressing on this. Okay? Let's start the second scenario, if you are ready, Dr. Sarah.
Okay, but I think, yes, also one of doctors said that the most common cause of septic is gonorrhea, right? But also Staphylococcal aureus can be one of the septic cause.
Yes, according to the source. So if we thought about sexual transmitted disease, it will be gonorrhea. If about IV drug abuse, it will be by Staphylococcus. This is according which is which. Okay. And
Okay.
again, yes, one thing more. Sorry, Dr. Sarah, I will interrupt you, but the injection marks in this patient, you should do also as examination in the peripheral examination. The hand, cubital area, even inguinal area for injection mark is very important.
Because he
Yeah.
might have.
Sorry?
He might have abscess. Yes.
Yes, abscess or even the injection, active injection mark or recent crust or needling.
So,
We know
but
it.
he
Yes.
asked one question regarding I told him what is the source of septic arthritis. The most common cause is hematogenous spread. Okay.
Yes. Mhm.
Hematogenous spread, and then it can be from nearby organs as bone, osteomyelitis, or soft tissue. But the most common cause of spread for septic arthritis is hematogenous from blood. Okay.
Yeah. I remember also by your talk now, the diabetic patient, there is also other organism will be common, I guess, Streptococcus. If there is cellulitis, for example, with diabetic patient, the septic arthritis will be different in the organism. It will be Streptococcus, spreading from the nearby organ, as you said. But for drug abuse, it will be blood, hematogenous, and it will be Staphylococcus aureus. This is another organism.
And in sickle cell from salmonella.
Yes, salmonella, exactly. But the good question also by Dr. Abdul Manaim, any past medical history is very important to ask. Maybe this patient immunocompromised and he got infection frequently and it will be like HIV or any immunosuppression related or any immunocompromised patient like cancer with the chemotherapy or whatever. Okay.
Dr. Basil, in
Yes.
the clinical judgment, when the surrogate asks what you would do to me now, I think admission first, I would say admission,
Yes, of
right?
course. Admission, yes. Septic arthritis, if not treated, it will lead to septicemia or maybe also preceded by septicemia. And if not treated, it might be septic shock and the sequelae of septic shock, multi-organ failure up to death. It's serious infection.
Yes, sorry, but another point, yes, this is the IV drug abuser, this solid source of infection. But I think what also surrogate raised issue of some flow or source flow before 5-6 days, right?
Yeah, it was, yes.
Can be source of septic arthritis if it is bacterial.
I remember Streptococcus, rheumatic heart disease, also can affect the kidney and the joint, but it will be in young age. Dr. Sarah also can
What I
other
can
infections, Streptococcus post tonsillitis or post upper respiratory tract infection as rheumatic heart disease.
no, but yes, it can cause. You mean
Yeah.
infection?
Post streptococcal, yes, post streptococcal. I remember post streptococcal might lead to
Glomerular.
kidney, glomerulitis or rheumatic heart disease, and also for joint.
But
Might
not
But it's not
septic. Not
not
septic.
septic,
It's
yes,
reactive
not septic.
reaction.
Yeah, not septic.
Autoimmune, yeah.
Yes.
Yeah,
No, I
but
mean, it is actually one of the criteria of rheumatic fever, arthritis.
yes, as
The major
yes,
criteria,
exactly.
arthralgia, minor criteria.
Yeah, but not septic. Yes, it's inflammatory response, but it's not septic one. Yes, but
Okay.
it's
No,
involved in an infection. Yes, yeah. What else? The question? You have any other question?
no, it's the same thing. Like diagnosis of it can be rheumatic fever also. Maybe
Rheumatic
both
fever. Yeah, but the arthritis here is septic clear. There is
septic,
redness.
yes.
Yeah, redness, swelling, hotness. So it's clear is septic arthritis.
Yes.
Trauma, important question here. It might be also hemorrhagitis, but once trauma is out, rolled out, so don't put it in the differential. Okay. Ready to start the case?
Yes.
Okay, let me read the scenario because I didn't read. Mr. Brandon, 40 years old, present with sensory loss. Okay. If you're ready, we can start.
Start.
Variable. Yes.
Hello?
Hello?
Am I talking to Mr. Bradley?
Yes.
My name is Dr. Mahmoud. I'm one of the doctor here in the clinic. Can I confirm your age, please?
Yes, I'm 40 years old, doctor.
Okay, so I'm here now because I can see from your notes that you are coming with sensory loss. So I need to ask you more about this, and I might take from you some history and ask you some question, and I will examine you. And at the end, I will address your concerns and we'll try to get the bottom of this. Is that okay with you? Okay.
Sure, doctor.
So it's saying in your notes that you're having sensory loss. Can you tell me more about this?
Yes, doctor. My problem started like 2 months ago when I feel this pins and needles in my both legs.
So you're feeling pin and needles in both legs,
Yes.
and this started 2 months ago, correct?
Yes.
Okay. Any pin and needle also in your hand, or it's only in your leg?
Only my legs.
In your leg. Okay. And this pin and needle sensation, you notice it now. Have you noticed it before?
Sorry?
You had this sensation before, or this is the first time that you have this?
No, doctor, this is the first time.
And regarding the sensory loss, do you feel also when anyone is touching you, or when you wear your shoes, are you feeling?
I did not say actually, doctor.
You don't know. Okay. Okay. So with this pin and needle sensation, have you noticed any weakness also in your leg?
No.
No weakness in your leg. And any weakness in your hands or any
No.
part of the body? Have you noticed any change in your speech?
No.
Any change in your vision?
Sometimes, doctor, I feel this actually. I have some blurring of vision, especially when I'm trying to focus on something.
Blurry vision. Okay, when you try to focus on something. Okay. And just want to ask you some question, yes or no, if you don't mind.
Mhm.
Do you have any fever?
No.
Any change in your weight?
No.
Any rash in your body?
No.
Any shortness of breath?
No.
Any cough?
No.
Any heart racing?
No.
Any change in your bowel habits?
No.
And what about your water work?
No problem, doctor. Think it's okay.
You notice that you are going to the loo more than usual?
No.
Okay. Any fast urine?
No.
Any pain while passing urine?
No.
Okay. And have you noticed? Do you have any headache?
No.
Any feeling you feel sick?
No.
Any night sweat?
No.
Have you noticed? You told me no change in your weight, right?
No.
Okay. So, do you have any medical condition of note?
Yes, doctor. I have high blood sugar.
High what?
High blood sugar.
High blood sugar. Okay. And how are you taking medication for it?
Yes, doctor.
And is it controlled?
I think my last test that the test that covered in the last 3 months is about 9, doctor.
9. Okay. 9. The blood sugar is 9. Blood pressure is 9.
The blood test that covered in the last 3 months.
So you have high blood pressure or high blood sugar? Sorry, I didn't get it.
High blood sugar.
High blood sugar. Okay, high blood sugar. Okay. Okay. So, and you are taking any medication for this high blood sugar?
Yes, doctor.
What medication?
I'm taking insulin.
Insulin. Okay. So, and any other medical condition apart from the high blood sugar?
No.
Any medication apart from the insulin you are taking?
No, doctor.
Any over-the-counter medication or Redmi?
No. No.
And you told me okay. And just some question regarding your lifestyle. Do you smoke?
No.
And what about alcohol?
I'm not taking any alcohol, doctor.
Okay. And are you taking any recreational drugs?
No.
And do you have any headache?
No.
Okay. Any recent history of travel?
No.
Any family history of the same condition or family histories that I should be aware of?
No.
Okay. Any history of surgery?
No.
Okay. Any recent? Do you have any back pain or trauma to your back recently?
No.
Any pain in any inflammation or in your back or any part on your body?
No.
Okay. And okay. And what do you do for a living, Mr. Byrne?
I'm taxi driver, doctor.
Taxi driver. So I just want to advise you to hold your driving till we get the bottom of this and know the diagnosis. Okay.
Okay.
Okay. And the other thing, I would like to examine you now, and I might ask you some questions that I forgot to ask you about while discussing with you. Okay.
Okay.
First of all, I will start my examination by the vitals.
Vitals normal.
And now I will go to examine, I will do a full examination of the lower limb. I will check the power, the tone.
The tone is normal.
Power.
Power is normal.
Okay, and then I will check, I will coordination. I will do heel to knee, shin to
This
knee.
this in the group, can you see in the group? This is his right leg.
In the group. Oh, okay. Okay, so you have a lesion on your right leg, right?
Yes, doctor, but actually this is the first time to notice it.
You notice it now. Okay, so okay, so I need to check for this ulcer. I will check any pain on the ulcer.
No pain. No pain.
Any oozing or discharge.
No.
Any redness or hotness around the ulcer.
Sorry?
Redness or hotness around the ulcer.
No.
And the skin is not hot. Okay, so I will complete my examination to do the coordination heel to chin test, normal.
Normal.
And then I would like to test the reflexes, normal.
Reflex is normal.
Okay, and then I will proceed with the sensation in the four modality. First, I will do the fine sensation.
There is sensory loss.
Sensory loss.
Up to the knee.
Up to the knee. For the fine sensation.
Sorry?
For the fine sensation.
For all modalities.
So for the fine sensation and for the prick, pin prick till the knee, right?
Yes, for all modalities.
And even the vibration.
Yes.
And even the joint position.
Yes.
Okay. And now I will ask the patient to check for if he able to do heel to toe walking.
Heel to toe? What do you mean?
Heel to toe walking. He's able to do heel to toe walking.
Heel to toe?
Yes.
What do you mean, doctor?
By putting the heel of the leg and the toe in front of it like this.
Tandem gait.
Okay. Okay. Negative.
Negative. And then I'll check Romberg sign.
Negative.
Negative. Okay. So I need okay. So I need also to have a quick listen to the chest.
Normal.
I will need to do an eye examination by checking the visual field.
Visual field is normal.
And ophthalmoscopy. Any finding?
Yes, there is the features of diabetic retinopathy.
Diabetic retinopathy. Okay. So feature diabetic retinopathy. I need to check also the leg and the hand for any ulcers. Because the patient, I think, is not aware about the ulcer.
Mm-hmm.
And to check also the heel for Charcot joint.
Charcot joint. What do you want to know, or what you want to examine?
Any swelling or deformity in the joint.
Swelling or deformity? No.
Okay. So okay. So still I'm having. Okay. So I need also to. I need to complete my examination by checking the sensation in the hand quickly.
Normal.
Normal. Okay. And for glove for glove hypothesia, normal.
Normal.
Okay. So, Mr. Bandit, after examining you, I think
You still have a time if you want to ask any questions.
okay. So let me ask you. Okay.
Remember the diabetic complication.
Yes, and can you told me you don't have chest pain first. Okay, can I ask you, what do you do for living? You told me, right? A taxi driver. Okay.
Yes.
So, and how is this condition was affecting your driving and your life?
It affects a lot actually, doctor, because when I'm driving at night, I have some problem with vision.
Okay. And regarding the insulin injection, are you using them, taking them, injecting them in time?
Yes, doctor.
And you do a rotational injection?
Yes.
Okay. And okay. So I think I finished my examination.
Okay.
Because in the exam, I think for this lower limb examination, I will take the whole time.
No problem.
Okay. And I finished. I don't have things to say. Okay. So I would like to for this so I would like to admit you in the hospital because your blood sugar is not controlled. So and to do for you further test. Okay.
Okay.
And I will include this, I will ask the gland doctor and also the eye doctor to come to have a look at you, and then I will come back with you with the management.
Okay. Thank you, doctor. Okay. Present your case.
So I examined this gentleman who's presented with pin and needle sensation in his both legs.
Sorry, still 3 minutes. Did you ask for the concern?
Yes. So what is your main concern? So forget.
My concern, doctor. What's wrong with me, doctor? Is it treatable?
I highly
And
appreciate.
why I have this problem, doctor?
I highly appreciate your concern, Mr. Brandon. Is this pin and needle sensation that you are feeling in your leg? Is it because of it? Is the diabetes? So with we need to as I told you exclude a multiple team because we need to control your diabetes, and if your diabetes will be controlled, your condition will be improved. Okay.
Okay.
Okay. Finished.
Is it treatable, doctor?
The diabetes is the diabetes is a long-standing medical condition. But
Doctor, I already have diabetes, and the doctor explained everything about my diabetes.
yes,
I mean, in my current problem, is it treatable?
yes, this pin and needle sensation will be controlled with tight glycemic control. Okay, but the blurry in your vision, it could be we need to do some treatment for it. And but because it won't regress, but we'll prevent further progression of the disease in the mean of your vision. Okay.
I'm going to be blind, doctor.
I really appreciate your concern, and this is and I can see how it's difficult for you, but I want to assure you with good glycemic, with good blood sugar if you control your blood sugar well, we might stop progression of this disease, and it might not progress to this blindness, but it is it could be a possibility. Okay.
Okay, you can move to the examiner time now. Examiner question.
Yes. Okay.
Present your findings or present your case.
So I examined this gentleman who's presented with bilateral stocking sensory loss in the 4 modality. He doesn't have any signs. His coordination was normal. Romberg was negative. He was having a painless ulcer in the heel, which might most probably a neuropathic ulcer due to his diabetes. On examination of his eye, he was have picture of diabetic retinopathy. So putting all these together, this patient I believe that this patient have a peripheral neuropathy as a complication of diabetes with associated with diabetic retinopathy. And
Okay, well, doctor, which type this patient have? Which type of diabetes this patient have?
this patient has type 1 diabetes mellitus, I believe, because he's taking only insulin.
Did you ask when he got this diabetes, when he diagnosed this diabetes? You cannot
Yes,
swear that this patient has type 1 or type 2. It depends on the insulin. Even type 2 in the last stage can use diabetes insulin.
yes, okay.
Okay, so well, what do you think the cause of uncontrolled diabetes in this patient?
Because of uncontrolled, maybe lifestyle. I didn't ask about lifestyle.
Did you ask about his lifestyle
No,
or his dietary style?
no, I didn't ask about. But I asked about smoking only and alcohol. But I didn't ask. Yes, you are right.
Okay. So what's the differential diagnosis of? So what's your the final diagnosis?
Diabetic peripheral neuropathy.
Do you have what other differential?
Yes, my differential neuropathy because this patient has bilateral symmetrical. So it could be diabetic. The second one, it could be alcoholic, but excluded from the patient. Drugs, as cytotoxic drugs, or NH. It could be vitamin B12 deficiency. It could be also due to other metabolic condition as thyroid hypothyroidism. It could be as a part of paraneoplastic syndrome.
Okay.
Other causes, it could be, but it will be associated with other neurological finding for the peripheral neuropathy. As there is other causes, but I think it's not in this differential. This is only my main differential.
Okay. So what's the differential of this ulcer?
Yes, this ulcer. This patient has a neuropathic ulcer. The other because it's he's in the heel of his leg. It could be vascular, venous.
Did you check his pulse and the peripheral pulse?
No.
Okay.
Yes, so check the pulse and then. Okay, I
Yes.
should check.
What else? Could be yes, you are right.
Venous,
Silent in neuropathic
venous,
ulcer.
neu-
What other possibility?
could be venous ulcer, but it mostly in the medial malleolus. It could be
Yes.
arterial ulcer, but
Good.
on the chin or his leg. It could be also
Sorry?
infective.
Infective. Okay. So how we are going to manage this patient? How to investigate?
Yes, for this patient, I would like to complete my examination by do a proper, full neurological examination for this patient, and I would like to for him a routine blood test, including full blood count, renal function, liver function, hemoglobin
Yes.
A,
Yeah.
hemoglobin A1, and blood sugar,
Yes.
and hemoglobin A1C, and also hemoglobin, and also serum lipid profile.
Yes. Good.
And we can do for him also 12 lead ECG.
Sorry.
12 lead ECG.
Okay.
And blood sugar and urine for blood glucose.
Any specific investigation you would like to do?
Yes, I would like to do for this patient a nerve conduction and nerve conduction study, and maybe EMG, but I'm not quite sure. And
yes.
include other causes by checking the B12 folate, thyroid function, B12 folate, thyroid function. I think this.
Okay. So how you are going to treat this patient?
Yes, the treatment of this patient should include multidisciplinary team, including the diabetic team, the endocrine team, the diabetic nurse, include the pediatric team for his leg ulcer, and also the ophthalmology for diabetic retinopathy, and the dietitian, and might be the neurology team also.
Okay. Okay. So thank you, doctor.
Okay. So what is your comment?
Yes, wait, for still 15 seconds, doctor. So how you can treat this ulcer?
Yes, I think this ulcer will give the patient, he's not feeling anything in this ulcer. So no, if he has neuropathic pain, we'll give him gabapentin, pregabalin, duloxetine.
And which is first option for you?
So this gabapentin.
Duloxetine.
Duloxetine.
D for D.
Yes, yes,
D
yes.
for D. Diabetic, duloxetine. Okay, then gabapentin and pregabalin. Okay. What do you think? Is this ulcer is arterial?
Why I'm not thinking this ulcer is arterial?
Yeah. Do you think it's arterial?
I think the arterial will be painful.
Or what else?
According to the side also.
Yes. Why? What can help you to reach if this arterial or not?
The side is the arterial ulcer. I think it will be on the chin of
And painful. Here, painful side. The
and
only
Painful and
the,
also at the tip. Yes.
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 At the tip and also in the heel. The most most distal area for perfusion. Okay, the last question. What the test you can do to say this is arterial or not?
Arterial brachial pressure index.
Excellent. You can move to the next stage. Yeah. Okay, your comment, Dr. Abdulmanah.
Yes, you did very well. But the problem in diabetes history is very long.
Yes.
So whenever you find that you finish before the time, you need to revise your history.
Yes.
Regarding the diabetes history, actually regarding the presenting symptoms, you analyze the peripheral neuropathy. You ask about weakness. It's good, very good. And if there is weakness, of course, you're going to ask, is it floppy or stiffy weakness? And you ask about the other symptoms of TNS. So regarding the diabetes, and I told you that my hemoglobin A1C was 9. So your next step, why he is not controlled? You have to look for 3Ds, drugs, diet, and daily exercise. And if you ask me about my diet style or dietary habit, I will inform you that I like pizza, I like pasta, so I couldn't stop eating sugar, doctor. So whenever you find that this patient is uncontrolled diabetes, you have to look for 3Ds. Drugs, is he compliant for whatever, insulin or oral hypoglycemic drugs? And of course, before this, the most important question to know, when you diagnose with this diabetes. Since childhood, this type 1, or at the middle, or recent, at late, after 30 or 35, that type 2. Regarding, we will not go deep to the other types of diabetes.
You said 3D drug diet and what?
Sorry?
The 3D diet drug and
Drug, diet, and daily exercise.
daily exercise. Okay.
Yeah. This regarding the history of diabetes, you have to dig deep in, because you already reached the diagnosis. This is the peripheral diabetic peripheral neuropathy. And you ask about the other microvascular complication of diabetes, which was very good. But why this patient, this is your main, I think this is the main problem. He is uncontrolled diabetes. You miss this in the history. Regarding systemic review, you ask about other apathies of complication. You ask about retina, kidney, but you didn't ask about major macrovascular complication. I think you can ask directly, do you have any history of heart attack or no? Just for screening.
Hmm.
You asked me about alcohol or no? I didn't remember actually.
Yes.
You asked me?
Yes, yes.
Okay. So this regarding the history because it's very long for diabetes history. In the examination, whenever, for example, this you have this patient present with sensory loss, so the system involved is in your CNS. You should do full CNS examination starting from tone, power, reflexes, coordination, and sensation. I think you covered it, all of it. You ask for fundoscopy. You already find that he has diabetic retinopathy. You missed to examine for injection site, which is very important because you should ask again. You should ask yourself why this patient has uncontrolled diabetes. You check for Charcot joints, very good, but I think the more they will minus you if the patient with diabetes has ulcer and you didn't check for peripheral pulse. Definitely they will minus you, definitely. So if he has any signs of enlarged joint, for example for Charcot, look, feel, and move for examination. But please remember, always remember to check for peripheral pulse in patient with diabetes present with any complication, microvascular complication.
Okay.
Regarding the differential, for this is mainly sensory neuropathy, so we refer to differential diabetes, uremia, alcohol, and drugs. I think like isoniazid. If sensory motor, this is another differential. So regarding the ulcer, yes, it is heel ulcer, so it's most probably it's neuropathic ulcer. Venous ulcer in the medial malleolus, and arterial ulcer either in the tip of the toe, as Dr. Basim said in the peripheral or the last point for perfusion, the less vascular. How to differentiate between arterial ulcer and other ulcer? It's painful, and of course the site. In the clinical judgment, whenever the patient present with eye symptoms, whatever the cause, whatever the reason, in your clinical judgment, when explaining the disease, you need urgently to be assessed by ophthalmologist or eye doctor. This because might affect your judgment, clinical judgment, because this patient present with he has symptoms of blurring of vision, and you have evidence of diabetic retinopathy. So it is important to mention that you need urgently to be assessed by eye doctor or ophthalmologist. Regarding the investigation, you cover it almost all, nothing to add. And treatment, as you said.
And the peripheral neuropathy will be restored with tight glycemic control and the loss of sensation, or it will be permanent?
Sorry?
The peripheral neuropathy that you have and the loss of sensation, it restored with tight glycemic control, as I said, or it is wrong?
You mean reversible or irreversible?
No, it's not. So there is
Irreversible.
It depends. Yes,
name.
depend on the blood sugar control. If controlled, it will be improved.
No, Dr. Basim, the peripheral neuropathy will not heal. It is damaging nervous. You can't back. You just will manage.
Okay.
So it will not be reversed at all, or not improving the pain, and or the
The
peripheral
sensory
loss?
loss, no.
If he has,
Then return back.
continue.
Any damage from the diabetes will not return back, but we will stop the progression. Like when you advise the patient smoker for an COPD, the symptoms will may be improved, but no any regression.
But no regression. Yes.
The damage, yes.
Okay.
What happened, but you will like prevent
Progression.
other
You prevent the
complication,
progression.
progression. Yeah.
Yes. Okay. Go ahead, Dr. Abdelmenem. Sorry, we interrupted you. Dr. Abdelmanem, you're mute. Okay, I don't know, maybe he got busy. Anyway, let's comment. Well done, Dr. Sarah, but I think after this case, you will never forget the diabetic complication. Now you got how to manage and how to investigate, how to screen, starting from the history, onset, course, duration, or previous attacks, and so on. And the progression, of course, it will be progressive, and the association and the pain. And the good thing here, you ask for back trauma, any alarming signs, loss of control of the water work. It's important also here to rule out any local cause, I mean for the back, from the back. Radiculopathy, for example, but it's clear it's related to uncontrolled or poorly controlled diabetes. So let's start the diabetic complication from the head till the toe. Okay, start from the head. What do you think from the head as a complication?
He might have stroke, mini stroke.
Yes, stroke, mini stroke. So you can clearly ask this question: stroke or mini stroke? Finish the CNS as macrovascular. Then in the head also, what else?
He might have diabetic retinopathy.
Excellent. So this is another.
Yes.
Okay.
Then,
yeah, then let's go to the cardiovascular system.
yes, he might have myocardial silent myocardial infarction.
So heart attack.
Yes.
Heart attack. Okay. Also, you can, some tiny complication might happen, like candidiasis in the mouth or in the, yeah, you can ask this question, or you can do as in examination. But the major you have to ask. The macrovascular you have to ask. CNS and ischemic heart disease. And going down, let's go to the tummy or the abdomen. What you can ask in the abdomen, or what complication might happen in the abdomen?
He might have diabetic nephropathy.
Still before the genitourinary, I'm talking about GI.
Gastroparesis.
Gastropathy.
Yes,
Yes. Yeah, fullness, feeling fullness, any floating, a change of the bowel habits in the form of constipation, alternating with diarrhea, all that might happen, okay? And fullness also, early satiety, it might happen, okay? Then genitourinary, as you said, nephropathy. Okay, down more in the fertility or reproduction system, what do you think? Any complication might happen?
Infertility?
Yes, related to fertility.
Impotence.
Impotence, excellent. You can ask why, sorry for this question. Can I ask you this question? Yes. You have any problem in your intimate relationships? Yes, doctor, I cannot maintain, I cannot perform well, whatever. So you can ask this question as a complication for reproduction, which is impotence. Okay, going down more for the thigh.
I think for the lower limb, he will prefer neuropathy.
And in the thigh, before there is a complication in the thigh. You remember it?
No.
Amyotrophy. Yes.
Okay.
Okay. It's not common, but remember from head to toe, you can pass by the thigh and remember it. Okay, in the leg, what complication?
Sorry? Peripheral neuropathy and peripheral arterial disease.
No, the leg before going to the feet, there is complication happen in the leg. Some rash.
Necrobiosis lipidicum.
Excellent. This might happen also, and the patient might present with this rash. There was a case with this presentation, skin rash and diabetic patient. Okay, the last thing in the feet, as you said, peripheral neuropathy and the whole types of ulcer, the neuropathic, arterial, and venous. And everyone, you can know how to differentiate and how to ask about. This is regarding the history. If you did this history from head to toe, you will not miss any complication. Let's go to the examination for diabetic patient, starting from the hand. What you suspect in the hand?
Peripheral neuropathy.
Okay, apart from peripheral neuropathy. Very simple thing.
Fungal infection. Needle prick.
Yes, exactly. Needle prick. So you have to check, yeah, needle prick marks everywhere in his all fingers. Okay. Then the pulse, you can check also for the pulse in the hand, and peripheral neuropathy and the power and so on. Paroxysmal myopathy also you can examine. Blood pressure, can ask also for blood pressure if there is associated hypertension. This is from the hand going up. In the face, as you said, if the patient having blurring of vision, what you start to examine first? Doctor, I have, yeah, what?
Visual acuity.
Yes, exactly. Okay, if any affection in the visual acuity.
And then and any affection of visual acuity?
Yes.
I don't know.
Okay, if the visual acuity is clear, you can proceed for the field, right?
Yes.
Okay, if affected, don't proceed for the field. So if he can't see your finger, how you can examine the field? Is it clear? Okay.
But the visual to check if he is able to see at 6 meters or something like that. But he might wake him see my finger.
First, yes, counting the fingers. Then if he count the finger, you can move your hand. If he can see moving the hand, you can produce light. If he not feel or see the light, then you can label him as blind, right? So if like this, you can't proceed for the field. Okay, let's go after the field. What you can examine?
Is the ophthalmoscopy.
Exactly, yes. What you suspect?
Diabetic retinopathy.
All retinopathy complication, hard, soft exudate, and maculopathy, photocoagulation, I mean laser for the, yes. This is for the eye. What complication you might have in the eye with diabetic patient?
Complications, a hemorrhage or no?
Okay, but I mean for the other nerves. I mean fourth and sixth and third.
I don't palsy. I don't know.
Yes, third nerve palsy. It might happen with diabetes. Yes, cranial nerve, third nerve palsy. How the patient will present with?
The eye will be you will have mydriasis and
Excellent.
eye down and out.
And excellent, yes. Down and out and mydriasis. This is for diabetic reason. Okay, let's go to the face again. The mouth, you will examine for candidiasis. Okay. And for the heart, any association of ischemic heart disease, you might have any murmur or heart failure signs or symptoms. Raised GVP by basal crackles at the back. Then abdominal examination, just quickly. Sometimes it's not, because of the gastropathy, you will not find something important in the abdomen.
Yes.
Whatever. Okay. Proximal myopathy in the thigh, then the feet and the leg before going to the feet, the legs for rash, and very important sign in the leg, what you can notice in the leg.
Trophic changes.
Excellent. Trophic changes in the form of shiny skin with loss of hair. Yes. Right? Okay. Then peripheral neuropathy, examination of the whole modality of sensation and reflexes. Don't forget the reflexes and the power. Okay. What do you expect the reflexes will be?
Reflex, I think it will be normal.
Why normal? Peripheral neuropathy. So you will have. What about the Beniski? Upgoing or downgoing?
Or has upper motor neuron.
Is it upper motor neuron? Are you sure?
Is Babinski?
Peripheral neuropathy is upper or lower?
It's up. So spastic hyperreflexia.
Peripheral neuropathy, Dr. Sarah, focus. Peripheral neuropathy is upper motor? Peripheral
لا lower.
neuropathy.
بس
Okay.
I think the It will be muscle weakness, but I think he might not have the full picture of low motor neuron, right?
No, he will have lower motor in the form of areflexia. Sometimes they have distal neuropathy, distal myopathy or distal weakness.
Weakness,
It's,
yes.
yeah, it's okay. So it's lower motor neuron. So areflexia will be there and downgoing plantar, not upgoing. Unless patient has or had history of stroke, it will be upgoing.
Yes.
Okay. This is the only exception you can have in the exam in neurology, patient with upper motor and lower motor neuron in the same limb. If he is diabetic with stroke, you might have features of upper motor mixed with lower motor. So you might have hypertonia, hyperreflexia in the knee, but in the ankle it will be areflexia and downgoing plantar. It will be mixed features of upper and lower motor neuron lesion. Okay?
Okay. Okay.
Yes.
مع الإضافة صغيرة
أهلين أيوة تفضل دكتور هند. أهلين دكتور هند كيف حالك؟
الله يسعدك يا رب. الفيجن اكزامينيشن حكيته على الثيرد cranial nerve palsy الميديكال.
Yes.
طيب
Yeah,
لو
we
عندي
can-
مثلا لو عندي third وعندي 7 patient diabetic, how you will explain the presence of third cranial nerve palsy medical with the sparing of the pupil and also facial nerve palsy lower motor neuron lesion. تمام. فلازم دائما نتذكر انه بنحكي على النيرفز في شيء اسمه مونونيورايتس مالتيبلكس، وهذا كمان
Yes.
which
Yes.
is multi-nerve affection not anatomically related. تمام.
Yeah.
DM one of the risk factor for this cranial nerve palsy. أو حتى ممكن تلاقي third مع right leg, third مع left arm. it is multiple nerve not anatomically related. could be one nerve. حتى third حتى الميديكال third cranial nerve palsy شو اسمه الثاني؟ mono neuropathy. اسمه مونو نيوروباثي لأنه نيرف واحد أفكشن. فلازم نتذكر المصطلحات هاي مونو نيوروباثي مونو نيورايتس ما لهم متخبين عندي. تمام. this is important. هلا ولما بيكون في عندي peripheral neuropathy it is usually not reversible. but what about mononeuropathy و mononeuritis multiplex reversible ولا لا بالدايبيتس؟ هون السؤال. it is reversible. it usually reversible. إنه أنا بصير في عندي medical third cranial nerve ولا 6 cranial nerve ولا حتى الفاشيال usually it take around 1 to 2 months to improve. نفس الميكانيزم of affection مو عن طريق degeneration of the nerves. نفس blood supply تبع النيرف become affected by somehow get ischemic. فلما بيتحسن diabetic control blood supply للنيرف بيتحسن وبالتالي it can recover. بينما بالperipheral neuropathy نفس النيرفز itself بيصير له degeneration وتلف بنفس الأعصاب الطرفية. تمام. different mechanism. طريقة هي مختلفة عن طريقة هي وبالتالي الحمد لله المونونيورايتس مالتيبلكس أو المونونيوروباثي are reversible. فلو إجاكي patient عنده medical third cranial nerve palsy وسألك بنهاية الconsultation دكتور am I going to get better, you will encourage him to improve his diabetic control and you will tell him that with time it differs from one person to person but it might take few weeks to a few months where you will gradually experience improvement. تمام. in your vision, in the diplopia or whatever he's experiencing. تمام. فهذا من السايد افكت كتير مهم تبع الدايابيتس اللي هو المونونيوروباثي مونونيورايتس مالتيبلكس versus البريفرال. انت لما سألك دكتور باسم على موضوع البريفرال علقت معك بكم موضوع انه قلتي كلمة it's not usually full picture. كلامك صح لانه بيفرق لو كان sensory عن لو كان موتر عن لو كان sensory موتر. تمام. فأتمنى انه يكون هذا اللي لخبطك.
Yes.
Okay.
Thank you.
Diabetes usually initially start as a sensory very benign يعمل لك numbness tingling. تمام. بعدين if he didn't improve his control السنسوري حيقلب sensory superficial أول شيء، بعدين superficial وdeep، بعدين بيقلب superficial وdeep و start to involve الموتور. فالموتور هو آخر شيء. وطبعا لو لقيت الريفلكس is lost this is a very advanced long standing DM peripheral neuropathy. تمام. ended up by loss of reflexes. Charcot joint ما بعرف إذا أنتوا قلتوه ولا لا.
قلنا
قلتوا الشاركوت.
Yes,
ممتاز.
mentioned this.
تمام. الشاركوت joint is also the most advanced picture. حكيتوا على الأوتونوميك complication.
Yes.
The blood pressure sitting standing is one of the things we can examine. تمام.
Mhm.
الأوتونوميك usually له contribution بالشاركوت، له contribution بالاتروفيك changes، وله contribution بالبلد بريشر والجاستروباثي مثل ما قال دكتور باسم، بس يعني nothing to help us to examine، بس mainly the blood pressure sitting standing. ممكن تحطي ايدك على البulse you are expecting the patient to have what tachycardia at rest. تمام. فالpatient will be resting he will have tachycardia. This is one of the disturbance of the autonomic nervous system. So take care of the pulse in these patients يعني it will help you too much.
Yes.
كمان في شغلة كنت بدي أقولها
The hypoglycemia also we didn't
yes
mention the
عليك.
hypoglycemia
أنت
unawareness.
بس الهايبوغلايسيميا حياخدنا لأذر فايندينج بالدايابيتك بيشنت. شو هن؟ غير الفينجر بريك مارك. هي الفينجر بريك مارك القصة القديمة قبل ما يخترعوا الديفايسز الجديدة اللي هي
CGM.
عليك
CGM.
نور. هلا ما حتلاقي فينجر بريك مارك. هي فينجر بريك مارك عفى عليها الزمن. هلا بالجي سي ام I should really ask the patient if he is having any device. إنه أحيانا ممكن يكون مغطى بالتيشيرت، ممكن يكون
اللي بقى
in the upper.
ال
اسمع
Continuous glucose monitoring. Yes.
اللي
glucose
البيضة اللي بتبقى موجودة في
Yes, on the arm.
أيوة اسمها
عبارة عن ديسك، عبارة عن
CGM.
ديسك مثل الليرة الحديد، اسمه CGM Continuous Glucose
Labor.
Monitoring.
Labor device.
الليبر ديفايس هو شوف أحسن نستخدم الكونتينوس الجي سي ام
Yeah,
كونتينوس
I mean
السي جي ام.
example. Yes.
بس اكزامبل لو قالوا لك شو الشركات المصنعة أعتقد كان في واحدة اسمها ديكسكوم وليبر، واللي بتقريها بالجوال بالسكان، واللي بتعطيكي continuous monitoring من دون ما تعملي سكان. في أنواع كثيرة لكن الاسم الأمبريلا تيرم تبعها continuous glucose monitor، ومو موجودة يعني ممكن تلاقيها بالآرم بأماكن ثانية كمان. تمام. finger prick mark is thing you can find. If you didn't find the finger prick mark look for the continuous glucose monitoring. والهايبوغلايسيميا قلناها you should ask for urine dipstick. تمام.
أوكي تمام شكرا جدا.
Yes.
هذا جزء من الأجزاء اللي you will not examine but you can offer. تمام.
Yes. Okay, thank
إن
you.
شاء الله ما كان ماشي. وعن جد شكرا كثير، كانت مراجعة رائعة باي دكتور باسم. إلا تذكرت آخر شغلة بالآي. شوفي غير المونونيوروباثي والدايابيتك ريتينوباثي في ماكيولوباثي، وفي عنا لسه واحدة جلوكوما وفلكتويشن اوف ذا فيجن اللي هو الريفراكتوري
Yeah,
ايرور
lens.
اوف
Yeah.
بالاوزمولاريتي. وليش قلتها؟
It's much.
لأنه عن جد عليك نور عليها سيناريو كامل. فخلص راجعته حطوا كل الكومبليكيشن يعني ما تنتسى. خلص الاي مونونيوروباثي، مونونيورايتس مالتيبلكس، البابل مو البابيلوديما، الدايابيتك ريتينوباثي، الماكيولوباثي بيفرقوا عن بعض. الدايابيتك ريتينوباثي you don't need to urgently refer the patient للأوفثالمولوجي، بينما الماكيولوباثي you need it's more acute. تمام. و it affect the reading، مو مثل الدايابيتك ريتينوباثي generally vision will deteriorate، ما يعني not the reading specifically I mean center of vision. بينما الماكيولوباثي he will tell you I cannot read. تمام. فالماكيولوباثي diabetic retinopathy refractory error of vision والنيرف affection هدول كلهم كتير مهمين بالدايابيتس. طبعا ماشي معهم كل الكرينيال نيرف، يعني حتى الفيشل ممكن يجي مونونيوروباثي من الدايابيتس. اتفقنا؟
تمام، شكرا جدا.
Yeah. Thank you, Dr. Hamid. Thank
شكرا
you so
كثير
much.
دكتور بعد.
Most welcome, Dr. Hamid. Okay, let's
One more
move to the
point,
communication.
Dr. Bashim,
Yeah.
one more
Yes,
point
sure.
in autonomic neuropathy. In the history, you have to ask for male patient, you have to ask about intimate relationship, specifically for erectile dysfunction.
Yeah, we mentioned in the revision. Yes, you're right.
Thank you.
I called you many times, but I think you got busy.
Yeah, I have connection
But it's okay. We
issue
mentioned.
actually.
No problem.
Sorry.
We mentioned, yes, the impotence and the intimacy. Okay. Thank you, Dr. Arminan, for a nice case, and Dr. Sarah
Basil?
also. It was nice case. Yes, sure.
Sure. Regarding meiosis and mydriasis في diabetic neuropathy في الآي، هو بيكون
Yes.
ميدريازيس ولا ميوزيس والسيرجيكال ذات؟ في واحد
The,
سيرجيكال نيرفالسي.
the surgical one will be without, because the
without what?
compression from outside.
معلش يا دكتور باسم، ممكن تقول حكاية
So
السيرجيكال والميديكال دي؟ معلش أنا نسيتها.
Okay. When you have the third nerve affection by the diabetes, what fiber will be affected?
The
النرف.
inner fiber of the third cranial nerve. So the
Yeah.
pupil reaction will be preserved. The parasympathetic supply will be
Will
good.
yes, it
And
will be
instead,
preserved. Yes.
the opposite for surgical, where the compression will be
From outside.
from aneurysm. So you expect to find the pupil is dilated.
Yeah, so it's the opposite. I mentioned the opposite, yes. And the
Yeah.
the
Yes.
In
surgical,
compression,
yes.
dilated. In diabetic, preserved. It's
Yes.
okay.
Yeah, because the compression from outside and the parasympathetic fiber in the outward of the nerve cable. So from compression from outside by either communicating arterial dissecting aneurysm, yes, will be compressing from outside on the nerve. So you will find mydriasis. In the opposite side, the diabetic fibers get blood supply, and the most distal area for the supply will be the inner cable. So the pupil will be not mydriated. I mean meiosis or no mydriasis. Okay, clear now. So
تمام.
the compression parasympathetic is in the surrounding or in the the cable from outside, compression from outside. But
part-
the diabetic will be the inner. So the outer and the inner. The parasympathetic always the outer layer.
Mm.
So it will be affected by compression. But in the diabetes, the inner will be affected, so the parasympathetic will be spared.
تمام، شكرا.
Okay, the surgical will be mydriasis.
Another point.
Yes.
Another point in abdomen may be found hepatomegaly secondary to the NASH, as diabetic is a strong factor for
Metabolic
non-alcoholic
syndrome.
steatohepatitis.
Yes, and also combination of metabolic syndrome,
Yes.
part of yes, you're right.
التايب 1 حلو دائما نتذكر انه التايب 1 اوتو اميون diseases. يعني انا لو in addition to all اللي حكيناه، كل اللي حكيناه، you will look for vitiligo, you will look for hyperpigmentation of Addison, you will look for thyroid لو type 1. لو كان type 2 ال additional findings اللي we will look for هي ال findings of metabolic syndrome اللي هو
Yes.
peripheral vascular disease, dilated cardiomyopathy أو ischemic cardiomyopathy, الستروك اللي هي upper motor neuron lesion signs, الناش اللي هي الهيباتوميجالي، الأوبيزيتي، الأوستيوارثرايتس مع الباك بين، الOSA. فأنت بشكل عام لما بتيجي بتحكي على الدايابيتس it's really important to know you are screening a patient who have type 1 فحتركز على الاوتو immune association كadditional finding، ولا انت عم تحكي عن type 2 فحتركز على metabolic findings كassociation للtype 2 تبعك. ف يعني this is additional findings usually help you to diagnose الكيس أو give differential. تمام.
Yes.
مثلا الدايريا differential in diabetes بتدخل فيها الدايريا
Celiac.
related للأوتو إميون، والفوميتنج كمان الفوميتنج related للأوتو إميون.
And thyroid as
فدائما
well. Yes.
it will help you to give more differential لو فكرت فيها type 1 ولا type 2.
Yes, exactly. So according to the age, even DKA complication, it will be as a case of diabetic and controlled diabetic. It came recently as a case, DKA patient. So you will screen also for the association of type 1 diabetes as autoimmune polyglandular syndrome. Okay. DKA, one of the complications of type 1, more common than in type 2. Type 2 will be presented with HHS, hyperosmolar hyperketotic state. Much more common with. Okay, any other point or comment before going to the communication? Okay, Dr. Abdullah and Dr. Bara. Yes, the duration also. Nice discussion for the case. Diabetic will never be end in the discussion. We can talk for many hours.
السلام عليكم.
وعليكم السلام.
في نقطة مهمة نسيناها إن our patient هو أصلا driver taxi driver. What about
Yes.
his license and DVLA information خاصة إن المريض on insulin
Yes,
uncontrolled
we mentioned.
diabetes.
Yeah, we mentioned we have to inform DVLA and to stop him for further
Maybe I'm not
assistance.
Yes.
It was something mentioned in the scenario, so we are not discussing it again. But if not discussed, we are reminding. But
no, I think
anyway,
it is not discussed. We should insist the patient to stop driving.
We thought.
yeah. I mean, she said it in the scenario in the history taking. She said to him, yes. Maybe you didn't hear, but yes, it's important to stress on this point, either from the unawareness hypoglycemia as hypoglycemia attacks, or even the blurring of vision. He also stopped driving, or even the peripheral neuropathy. He can't feel the feet also can affect his driving. So you can involve the occupational for help.
Yes.
And he should inform the EVLA. Yes, you're right. Thank you, doctor, for your comment.
Yes, Dr. Bas.
Okay, Dr. Abdullah, Dr. Al-Bashir.
Yes.
Dr. Al-Bashir. I don't know if he knows about our meeting or is it late for him? I don't know. He messaged me for the first time to practice. Dr. Al-Bashir, let me send him message.
معلش دكتور باسم، ممكن
Yes.
تقول اصل هما بيسألوا سؤال ايه هي المايكرو والماكرو فاسكولار كومبليكيشن؟
الماكرو major vessels like coronaries,
stroke and heart, right?
Heart and stroke and CNS.
And peripheral artery disease. And والمايكرو retina renal peripheral neuropathy.
Yes.
Okay.
Peripheral neuropathy, retinopathy, and nephropathy.
Okay, see.
Most well. Even nephropathy, you can put it with the macro because the renal vessel, but still you can put it as micro. But retinopathy and peripheral neuropathy are with the microvascular. Okay. Dr. Al-Bashir, I don't know his. I messaged him, but he didn't reply.
Hello.
Anyone here willing to do? Yes,
here.
Dr. Bashir?
Yes.
Yeah, okay. Will you start first or Dr. Abdullah first, as you like? Just arrange together.
Okay.
You can give me the scenario.
Okay, I will give you the scenario. Okay.
Just tell me where did you write the scenario?
I'm writing here in the
Chat
chat.
box? Okay. Okay.
Yes, sir.
Dr. Abdullah, also you can write your scenario. If you will take time also, you can write it from now in the chat box. Yes, Dr. Abdullah, you have 55 years, has been diagnosed as pheochromocytoma by your team. He has been followed by GP for 4 years as white coat hypertension. Okay. Occasionally we just practiced this scenario yesterday, but it's okay. Let's do it again.
اوكي ما هو كده اغيره طيب انا.
No, it's okay, Dr. Bashir. Let's do it. Maybe he didn't do it, Dr. Abdullah. So let him practice this scenario. Put the
Okay.
patient name, Mr. Zaki, for example, or whatever. Dr. Abdullah, ready? Mr. John, okay, good.
Yes, okay, no problem.
Ready or
Mr.
we can?
And my role. Okay, no problem.
Yeah,
And as my role,
Okay, you are a senior house officer in the
medical clinic.
medical team.
Yes, yes, I'm ready. Dr. Bashir.
Okay.
Okay, just
Sebastian,
give
can you
me.
raise
Yeah,
the
just
stopwatch?
give me a second. I will log out, then I will join again because the Zoom is hanging with me. Give me a second. I will come back.
Okay.
Okay, I'm back. Let's adjust the timer, then you can start straight away. You ready?
Yes.
Yes, here you go.
Hello there.
Hello?
Hello there.
Hello?
I'm Dr. Ahmed. I'm a senior house officer in the medical team today. I might talking to Mr. John.
Yes,
Okay, Mr. John, and you are like 55 years.
yes, yes, doctor.
Yes, Mr. Yeah, today we are here to discuss some issues related to your health condition. Okay, is that okay with you?
Okay.
And Mr. John, to be on the same page, can you tell me how much you know about your condition so
Okay, doctor. I'm just following my doctor in the clinic. Uh, I have a lot of symptoms for a long time, about 4 years. He just uh, labeled me as a white coat hypertension. Well, after 4 years, he bring me here to this hospital. Your team did for me a workup, and they discover I have a mass in my abdomen that is responsible for this high blood pressure. And I'm so angry about this. And I left
Mr.
more than 4 years without treatment.
Mr. John, thank you for sharing this information with me. Yes, as said that uh, our team did for you some test, and they found that you have high blood pressure, and the cause of this high blood pressure is a mass above in a gland above your kidney, which is called pheochromocytoma. And Mr. John, if you allow me, I can explain to you more about this condition, and also me say to you some points regard this diagnosis. Before that, please, uh, uh, you can ask me any question if it is not clear. Okay.
Okay, doctor, I do know, I know these issues. Your team explained to me what this mass, but I need to know why this all this period I working from my house to this clinic. He never mentioned to me this.
Okay, Mr. John, we can see that you are angry, and I highly appreciate your concern. If you allow me, I can explain to you in points what happened.
Okay, go ahead.
Yes, Mr. John, due to similarity in the symptoms, I mean as blood pressure readings, high blood pressure readings, uh, there is similar conditions. I mean they can share uh, the same symptoms or manifestation, like white coat hypertension and this diagnosis of pheochromocytoma. Okay. And also we are speaking about the common white coat hypertension, common, while pheochromocytoma is less common. And this may be the cause with delaying. I'm not defense about my colleague, and to be more sure about this point, I'm not aware about the situations. So this I can help you by contact the GP surgery, who is the person responsible in such a situation and can clarify more about this. Are you following me, Mr. John?
Doctor, I'm not convenient by your word. I think you are just defending on your friend, your doctor, your colleague.
No, Mr. John, it's not about defending about my colleague, but as I mentioned to you, this can happen due to similarity in the condition, and also and regarding the situation there with GB, the situation is not clear for me. To get more information about that, we can contact the GB surgeon. He can do some investigation about your follow-up, about your plan of treatment, and then he can give us the feedback about this.
Mm.
Is that okay, Mr. Joe?
Okay, I'm still not convincing by this talk, but I need to complain against him.
Well, Mr. John, you have the right to complain, and also I can help you and direct you to the office responsible for that. And as I mentioned to you, the GB surgery is person who can help in that. And be sure, or regardless your complaint, our treatment will be the same. Okay, Mr. John.
So, what you will do for me right now?
Yeah, okay, Mr. John. Now our plan of management I can explain to you. We will involve group of specialists, including the hypertension doctor who is responsible in such situations of high blood pressure, and also will involve the gland doctor and gland surgery doctor. And mostly, in most of the cases of this condition, as surgery will be the intervention after assessment, and also there is other medical options. This depend on the situation. Okay, Mr. Joe.
Okay. Okay. So, doctor, is it a malignancy?
I
Is it a
understand your
cancer?
worries. Yeah, I understand your worries, Mr. John. And Mr. John, in in a small percentage of this condition, it could be a cancer. Uh, Fortunately, most of the cases is benign. I mean, is not a cancer in origin. Okay.
Mm-hmm. So, any chance of this mass to recur again?
I appreciate this concern also, and yes, there is a small percentage also that it can recur. This depends on the nature of this mass, and this will be determined after the surgery and take a snip from this mass to know the
Two minutes
nature.
left.
Do you have any other concern, Mr. John?
Okay, doctor. So, do I need to take medicine for a long term for this high blood pressure, or, or just everything will be okay after surgery?
Yeah, Mr. John, I appreciate also this valid concern. This depend on the result of the after we do the surgery, or let to me explain to you in a manner that if you are suitable for surgery and we did the surgery, then mostly you will not need more treatment. And if after surgery, uh, the assessment showing that you will need treatment, this may be determined by the blood pressure doctor. Is that clear for you?
Okay.
Okay. Mr. Joe, let me assure you that we are here to support you, to treat you, to help you. And sorry for being uh, the sorry for being uh, ruled
Yes,
by
doctor.
this
Yes,
condition,
Dr. Abdullah.
and
Here,
just accept that.
I'm
Okay.
comfortable. Yes, I'm comfortable with this department and with these doctors. They have more informations. And your colleague, I think his knowledge is less about the medicine and practice.
Yeah, time is up. Let's start comment. Dr. Bashir first.
والله do comment أنا يعني this is my first time to be as a surrogate.
It's okay. So I will comment on behalf
Okay,
of
so-
you. Okay.
Okay.
Well done, Dr. Abdullah. Apart from the fluency for the answering, you have to be more fast in the reaction. Always when he or any surrogate saying to you any concern, appreciate the concern first. Okay. And while you are appreciating his concern, think what you will do or what you will say. This is your time lag to think what to do. So give to yourself some seconds while saying, I appreciate your concern. I understand how you are feeling now. I appreciate your worries, and prepare yourself what the answer while saying this. Okay. Always he's giving you concern, and you take some time to think. But in this time, instead of being quiet, try to appreciate his concern. Yeah, I appreciate your concern. But anyway, you answer all his concern correct, apart from the lag and the answer. So I want you to be more fast in answering the concern. They are commenting about everything in the exam. Okay, so let's start from the beginning. As you did, the performance was perfect. Started by the introduction, the confirming data, and information about the disease, and also about the expectation you can ask. And the good thing here that you didn't defend more and you didn't apologize. You don't know the whole situation, but you been sorry for him. I am sorry for your suffering and what you did and what you went through all this duration. And we are here to help you, to support you. Don't worry. In the coming days, we will be with you, our eyes on you, and we will give you multiple follow-up. You can just reassure him as much as you can to absorb his anger and to think what the next step. Yes, I want to complain. Okay, I agree. You can you can go back to your GP to ask him more about the details, what happened there. If he's still insisting, yes, I can refer you, or you can visit the GP surgery. They can help you in this situation. However, in meanwhile, I will help you by calling multidisciplinary team approach called a group of specialists. They will help you in diagnosis and managing the condition and so on. While explaining the disease, you said pheochromocytoma. Immediately, you can explain as you did. It's a overgrowth or the gland above the kidney secreting subprotein or substance which make you anxious and hypertensive, and it's similar to other condition which is white coat hypertension syndrome. That's why maybe it's similar, and maybe the GP couldn't suspect this, and it's a rare condition. And the second question will be for the cancer chance. Yes, it's minimal chance to be having cancer. And the next concern was about the surgery. Perfect answer. We will have the team meeting. We will see the case from the imaging, from the lab work, and we will update you about the possibility of surgery, if it's suitable for you or not. But whenever you hear 2 minutes left, you can ask about the concern. Even he's talking, you can start asking any concern. If no concern, you have to ask for the social. The social here is important. The diet, maybe he's taking high salt diet, and you can advise him or help him by calling the dietitian. You can ask for the smoking. It's very important. The alcohol itself, and the job. And in a stressful condition, it might also lead to the hypertension. So whenever you listen or hear 2 minutes left, you can go through this social unless he has other concern. But don't let him take the superiority to talk. If he's talk more, you can stop him to talk about your important point, which are social history. Okay? But apart from that, you have also to consider his concern the priority. If he has some concern, you have to answer his concerns. Is it clear? Okay, Dr. Abdullah?
Yes, Dr. Basmi, thank you.
Okay, most welcome, and great really as communication scenario performance. Just try to practice more and you'll be perfect in the future. Let's go to the next scenario,
So,
Dr.
Dr. Basil,
Yes.
if we need to categorize this scenario, it is not medical error, right? Not clear medical error. It is
Yeah,
uncertainty.
yes, we discussed this issue recently also.
I didn't attend, unfortunately.
Okay, let's make it easy for all of us. The most important and very good thing in the exam, they are categorizing the task in the paper. If they wrote for you medical error, go through the medical error step. If they wrote uncertainty, so don't apologize. Just be sorry for him. I am sorry for your suffer. So this is good thing in the exam and in the scenario. They are writing what's the task, what you should do. Okay, it will be clear. End of life care, it will come as end of life care. Medical error, it will be written medical error. So it will be clear for you. So don't, we will not go through, because if we have discussed this again, we will take a long time. And also there is some argument between no, don't apologize or apologize. Sometimes, yes, it consider as medical error because long time, 5 years or 6 years, and he didn't diagnose him. I think this is error. In the opposite side, sometimes the patient will not have the whole symptoms. So I can say the GP is right. So it's not medical error, uncertainty. So you don't know the clear situation and you can't judge as medical error from without history taking, I mean, from the scenario without history taking, unless they wrote for you medical error because the patient didn't diagnosed or wasn't diagnosed and he's angry and he has complication and he went many times to the GP. So we'll not go through all these details. Let's just hopefully wait for the task in the exam and it will show you either medical error or something else. Okay? But believe me, it will be written in the task.
Thank you very much.
Okay, most welcome. Dr. Bashir, any question? Any other comment or question before moving to the next scenario? Because I know the time is late.
No,
Okay.
no.
Oh, you are the doctor in the medical ward. Mr. John, 70 years, known case of hypertension and AF. He is taking warfarin. INR last was 1.5, target 2 to 3. Presented with left side weakness. CT brain showed right basal ganglia bleeding, and as per radiology report, most likely it's hypertensive bleeding. The task, talk to his daughter, Mrs. Mary, who is thinking that the cause of bleeding is due to warfarin. Just let me know if you are ready.
Okay, I'm ready.
Okay, great. Yeah, here you go.
Hello,
Hello.
I'm Dr. Bashir. I'm the treating doctor in the medical ward today. Am I talking to Miss Mary?
Yes, doctor.
Okay. Are you the next of kin of Mr. John, 7 years?
Yes, doctor.
Okay. So here we are here today. We are here today to discuss some issues related to Mr. John health conditions. Please, could you tell me what do you know about his condition?
Yes, doctor. My father uh, came to the hospital around 2 days ago, and he has weakness in his limb. Uh, they did for him a scan for the brain, and they told us that he had bleeding.
Okay. Sorry for that. But to be on the same page, as you mentioned, all what you mentioned is right. He has a high blood pressure and irregular heart beat, and he was taking the blood thinner called warfarin for the last period. Are you following me?
Yes, doctor.
Yes. We admit him here because of this weakness, and we did a lot of tests for him. One of them is a brain image, which showed uh, the bleed inside the brain.
Yes, doctor. I'm aware about that.
Sorry for this. Sorry for your husband as he passed through this bad experience.
Doctor, I think yeah, unless this hard doctor give him this medicine, he will not have this bleeding.
Okay, I appreciate your concern, but I would like to say for you something. We did a check for his the blood thinning. We find that the unit is called INR. We find it in the normal range. So it's less likely. It's not the warfarin is not a cause of the bleed of your husband. Are you following me?
Yes, doctor.
Okay. So do you have any more concern?
Doctor, no, I want to have complaint against this hard doctor. He gave him this bad medicine.
Okay, I appreciate your concern, but let me inform you that the 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 bleeding inside the brain is not caused by warfarin.
Okay, doctor. Okay. Now, who can I blame to have this bleeding? What could be the cause, doctor?
Okay, likely in his situation, the cause of bleed is due to high blood pressure, as the site of the bleed in the brain um, probably likely probably due to high blood pressure. So
Okay, doctor. What you will do for my father now?
okay, in order to treat your father right now, we are going to admit him in the ward, and we are going to stop the medication, the warfarin, which will be stopped by the blood doctor. We are going to join. We are going to make a team made by blood doctor, the nerve doctor, and physicians. They will decide regarding warfarin and the blood thinning medications. They are going to take care of him. We are going to follow his vital signs. We are going to follow his motor functions. Make sure we are going to follow your husband.
So my father is now become more trouble with this bleeding. And also the problem is that when you stop this medicine, he may have another complication. When you will restart this medicine, doctor?
Okay, I appreciate your concern. Up to now, we cannot know the exact time when we need to start this medication again, to restart these medications. But this decision will be made by the heart doctor and the nerve doctor after following his brain bleed by doing a serial image for him and to follow his general condition. Hopefully we are in the same page.
Yes, doctor, I get you.
Okay. Do you have more concern?
No, doctor. Thank you.
Okay, to summarize what we said, your husband came here with right side weakness, and he had taken medications at the blood thinner, and we find the image findings suggestive of the bleed. The bleed side is in favor of the high blood pressure at the cause. So we make a multidisciplinary team to follow his condition and to manage him in the best of the patient interest. Okay. Do you have more concern?
Doctor, is there any alternative for this medicine?
For the right now, this will be decided by the heart doctor and the blood doctor.
Okay, doctor. And what will be the outcome for my father?
Don't worry, I understand your worries, but we are going to follow him. We are going to follow him here in the hospital until his condition improved.
Yeah, it may
you
not
have a more
improve.
concern?
You mean that it may be not improved and may become serious?
And until now, we have no exact answer for these questions. But what we will do, we are going to follow your father, your husband condition here, and if the condition isn't
2 minutes left.
And I'm finished, I think.
No, 2 minutes left. Continue.
Yes, doctor. Doctor, what could be the option?
The option of treatment will be decided by the heart and the blood doctor. They might
Not just
prescribe.
option of treatment. I mean for the outcome. He will die. It will be serious. He will improve.
Hopefully, his condition might be improved, but all possibilities there. His bleed might be increased, and then don't worry, we are taking care of him. We have a surgeon will be beside us. If there is need for any surgical intervention, we will do it. We will do it.
Okay. Thank you, doctor.
In any support you want to ask Dr. Bashir? Any social history you want to ask? Still you have 20 seconds. Any leaflet brochure you want to provide?
This is my first trial.
Yeah, okay.
in
I
communication.
appreciate your performance, and really you did great as first time. And yes, I can feel the pressure and the stress on you, and the hesitancy also while answering the question. But actually, you did well. So I don't want to be like bad experience from first time. No, it's very nice presentation. You did very good in the performance and answering the concern, answering the questions. Let me correct some things, and next time will be more professional. Okay.
Okay.
Yeah. So I will start the comment. You first, you have to introduce yourself and confirm the patient data and the surrogate sitting with you. You are Mrs. X and you are the son for Mr. Z. Yes, I am. He is 70 years. Yes. You are the next of kin for him. You have to confirm this information. Yes, I am. We are here to discuss about his condition. If he's conscious, you assume that you got permission from the father to talk about his condition with the daughter. We are here to discuss about his condition, and we assume that we got permission from him. If he comatose or he lost the capacity, no need to say that because you can't talk to the daughter without any permission. Okay. What do you know so far about your father condition? Yes, he was taking medication, blood thinning, and he came with weakness. I think it's related to the medication. Okay, I appreciate your concern and your knowledge about your father condition, and we are here to support you, to address your concern, and to answer all your questions. Anytime, please stop me, and you can ask me any question. Thank you, doctor. Okay, you can ask her another question, doctor. Sorry, Mrs. Mary, what's your expectation about this meeting, and what do you think about our talk today? Yeah, I think your father, my father, was mistakenly taking this medication, and this is a mistake from your team. Every comment you have to start by, I appreciate your concern. I appreciate your concern. I appreciate your worry, Mrs. Mary. Let me explain to you the things here. Your father was taking medication for blood thinning, which is called warfarin. And suppose you are following, or your father following, in a clinic called INR clinic, and this clinic concerned to the follow-up of the blood thinner and the blood thinning level. Are you following me? Yes, doctor, I follow you. Yes, we are following with the clinic. And the last time, for example, she will say like that. Last time INR was 1 or 2 or whatever. Okay. Then let's go to the next step. The next concern, sorry. This medication mistakenly is, no, I appreciate your concern. No, it was in the best interest for his condition. You have to say this sentence always. Yeah, it's in the best interest. Why? Because you want to remove this idea and this thinking from here. And this is your task. It's a bleeding, or sorry, hypertensive bleeding. So you have to say, no, it's not related to the warfarin, it's related to the hypertension. I appreciate your worry, but it's not related to the medicine, even though the INR is not in the target. And this has happened because of another reason, which is high blood pressure, which he's suffering. Yes, doctor, he has this blood pressure since long time, and it's difficult to control, and so on. She will prove your talk. Okay, what you will do now, we will follow up your father, but don't say vital signs. Vital signs, one of the jargon. You can't say vital. We will follow your father and we will monitor his condition, and we will check his bleeding, follow up his bleeding. And the good thing here, you mentioned the group of doctor, which is very important thing. We call group of doctor, they will follow your father, they will do the best interest for him. Doctor, does he need surgery? I appreciate your concern again. The team will sit and they will review the image, and accordingly, they will decide either for surgery or not. When you will stop this medicine, or when you will resume this medicine, again, anything you can throw it to the multidisciplinary team. The team will sit and they will decide accordingly, and we will update you in another meeting. And whenever you have time, you can ask who's dependent on your father, what's his job, does he smoke, does he drink alcohol, any support he needs in the home. We can help you in this regard. And the smoking and alcohol you can ask about, okay? Any other concern? No, doctor? You can thank her, you can give her leaflet brochure about the complication, the INR, the warfarin, the side effect, and the ICH or the bleeding, hypertensive bleeding in his condition. In general, as first time, Dr. Bashir, you did all the things, but you just need to be more professional in the talk, avoiding the jargons, more confidence, and don't be hesitant. I can feel your hesitancy while answering her concerns. Okay?
Okay,
Sorry,
thank you.
Doctor. Yeah, well done, Dr. Bashir. Sorry, Dr. Abdullah, I comment before your comment. I'm so sorry for this. You can comment now, but I commented because he said it is first time for him, just to reassure and to give him some power. If you're there, you can comment, Dr. Abdullah.
Yeah, no problem. Yeah, thank you, Dr. Bashir. You did well. And I think for first time it is more than very. Yeah. Just to confirm the idea of the candidate, and also that his father or her father, not her husband. I repeat for you many times. The other thing is that in multidisciplinary team, you mentioned you need to involve the ordinates in the explanation of the condition. It's good. The introduction just to correct the idea. Then explanation of the condition. Then regard the explanation of management. Yes, multidisciplinary team. You mentioned multidisciplinary team in one of the sentences. It is jargon, as Basim mentioned. You need to avoid jargons. Then you need to involve the nerve surgery doctor and the heart doctor you mentioned. Other thing that when I raise a concern repeatedly, you need to know, you need to answer the concern. When I said I will complain the heart doctor, you need not to ignore my concern. Yes, you have the right to complain. Let me explain to you then to go in details. Then regards the outcome, yeah, you give me the answer after I repeat the concern many times. You need to tell me that this depends on after monitoring of your father. And yes, you mentioned that you will repeat the image or the brain image again. And sometimes the body is able to absorb this bleeding, and we hope this is your father condition. But I'm sorry to tell you, in some cases, this may progress, or the bleeding may increase and can affect the awareness level, and also can lead to jerking of the limbs. I mean, this regards the prognosis. Regards the alternatives, yes, you asked this concept. Then mm, what you will do for my father, you answered this concern also. Then about the social history, and this is here important to start by asking about the support and with whom your father living, and who support your father, and then to complete the other parts of the social. But you did well. You cover almost all the main categories or the main parts of the communication, and that's thank you, Dr. Bashir.
Yeah, thank you, Dr. Abdullah, also for your comment. Well done again, Dr. Bashir, as a first time. Just some confidence and trust yourself, you'll be more professional. Also well done by Dr. Abdullah in the first scenario. I think we are done with the session today. Any question, any comment from others regarding communication scenarios or clinical? Any question? Any comment before ending? Any question, Dr. Bashir, Dr. Abdullah?
No, thank you. Thank you.
Okay, thank you. Thank you too. We'll see you tomorrow, inshallah, with another day of practice. See you tomorrow. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.